Hello everyone and welcome to a new session about clinical pharmacology and drug therapy. Today we will continue our talk about the pharmacology of autonomic nervous system. The first session covered the introduction and the principle to the clinical pharmacology. In the second session we are going to speak about cholinergic agonist. Let's get started. Okay, regarding cholinergic agonist, we are going to speak about the first group of medication considered like direct acting cholinergic agonist. We have less of medication belong to this group. As you can see here, we have acetylcholine, bithanicol, carbachol, cevimeline, and pilocarpine. The second group, okay. The second group, we have indirect acting reversible cholinergic agonist. So we have less of medication about indirect acting reversible cholinergic agonist. We have imibinomium, donabazil, galantamine, neostigmine, physostigmine, beridostigmine, rivastigmine, and tacrine. Then we have indirect irreversible agent. Indirect irreversible agent, one medication, icothiopate, phospholine iodide. Then we have reactivators of the acetylcholinesterase. Here we are talking about bralidoxim. Okay. In this slide, we need to understand and maybe memorize the synthesis and release of acetylcholine from the cholinergic neuron. This is a schematic representative chart for the acetylcholine synthesis, uptake, and release. As you can see, this is a presynaptic neuron here. Moving to the next step. The acetylcholine synthesis starts from choline and sodium. The choline and sodium enter the neurons through the cotransporter, and with the availability of acetylcoenzyme A, we have the enzyme there, acetylcoenzyme A, AChEIs, lead to the formation of acetylcholine. So this is the first step, synthesis of acetylcholine. Then the next step here, as you can see, this is the first step, synthesis of acetylcholine from choline and sodium. Okay, the next step will be uptake. The acetylcholine will enter the vesicle. Okay, now you can see here the acetylcholine enter the vesicle. Okay, then due to the maybe accumulation of acetylcholine inside the vesicles, number one, and entry of calcium inside the neurons. This is called depolarization, action potential. This allows the vesicles to engulf on the end of the neurons, and engulfing into the neurons lead to the release of content of acetylcholine, and the releasing of content of acetylcholine in the synaptic cleft or in the gap. So now I will repeat. We have synthesis from choline and acetylcholine. Then we have formation of acetylcholine, uptake by the vesicles. The vesicles will release its content to the synaptic cleft. Okay, next what we have here, acetylcholine in the synaptic cleft will bind to the receptor. Of course, we have different type of receptor. Could be nicotinic receptor, as you can see, or could be muscarinic receptor. So we have two main type for acetylcholine, as you can see here. We have nicotinic receptor or muscarinic receptor. Here we call this space here synaptic cleft or synaptic gap. This is the first action of acetylcholine binding to the receptor. So I will repeat it. Now we have four stages. Stage 1, synthesis. Stage 2, uptake into the vesicles. Stage 3, release of acetylcholine. Stage 4 are binding to the receptor. This receptor could be nicotinic receptor or muscarinic receptor. Okay, another fate for the acetylcholine. The acetylcholine may bind to the presynaptic receptor. Another fate also for the acetylcholine. Acetylcholine may be metabolized by AChE, which is stand for acetylcholinesterase. So if you look what we have here for abbreviation, AChE stand for acetylcholinesterase. This enzyme responsible for metabolism of acetylcholine. So as you can see here, acetylcholinesterase responsible for metabolism of acetylcholine. This is stage number 5. This will lead to the formation of choline and acetate. Then we have the choline will be used again. We call this one uptake. This is stage number 6. So as you can see here from this graph, we have 6 stages or 6 steps for acetylcholine from the synthesis until reuptake. Synthesis, uptake by the vesicles, release of acetylcholine, binding to the receptor, binding to the presynaptic receptor, metabolism of acetylcholine, and reuptake by the preganglionic receptor. And this steps of synthesis until reuptake of acetylcholine, we have some medication may affect these steps here. We have it here on the screen now. You can see here we have, for example, pilocarpine. Pilocarpine stimulate muscarinic receptor. We can see the plus here will stand for stimulation. So pilocarpine stimulate muscarinic receptor. On the other hand, atropine block the muscarinic receptor. What else? So we have botulinum toxin, Botox. So the Botox here, you can see it stands for botulinum toxin. Botulinum toxin, Botox inhibit release of acetylcholine. And we have spiderphenol enhance release of acetylcholine. So the Botox, this may be botulinum toxin. This toxin may be used for the treatment of wrinkles, the wrinkles around the eyes or on the face. And the main mechanism of action, as you can see here for the Botox, the botulinum toxin inhibit release of acetylcholine. And we know that acetylcholine causes skeletal muscle contraction. In this case, the Botox will inhibit the release of acetylcholine, and this will lead to the skeletal muscle relaxation and remove the wrinkles around the eye. Another interaction on this image and this graph here, we have a group of medication that able to inhibit acetylcholinesterase. So we have a list of medication can work on that. So if I clean this one here to show you the minus here, so you can see here we have list of medication able to inhibit this enzyme. And when you inhibit this enzyme, and we know that this enzyme responsible for metabolism of acetylcholine. So when you use this acetylcholinesterase inhibitor, when you inhibit this enzyme, the result will be increased level of acetylcholine in our body. Okay, regarding a list of cholinergic agonists, we are talking here about the medication belong to the cholinergic agonists. So the first group consider like direct acting cholinergic agonist. The second group will be indirect acting reversible cholinergic agonist. Then we have indirect acting irreversible cholinergic agonist. The last one, reactivator of acetylcholinesterase. So the first one direct acting, the second one indirect acting reversible, and the third one indirect acting irreversible, and the last one, number 4, will be reactivator of acetylcholine. Okay, start with the list of medication here. Direct acting cholinergic agonists. These drugs bind directly to the acetylcholine These drugs bind directly to the acetylcholine here. We have list of medication, as we mentioned: acetylcholine, bethanicol, carbachol, cevimeline or cevimeline, and bilocarbin. Regarding the indirect acting reversible, less of medication. How this medication work? Indirect acting reversible this medication considered like cholinergic agonist. How this medication work? This medication work by indirect acting reversible. That means this medication will leave the receptor after a specific time, for example. So this medication inhibit enzyme responsible for metabolism of acetylcholine. This enzyme called acetylcholinesterase. So this medication inhibit acetylcholinesterase. This enzyme responsible for breakdown of acetylcholine, and this will lead to the increased level of acetylcholine. Regarding indirect acting reversible cholinergic agonist, list of medication we have there: imipenem, danabazil, galantamine, neostigmine, physostigmine, pyridostigmine, rivastigmine, and tacreme. So we have list of medication here. How this medication work? Again, we need to explain it in a simple way. As you can see here, we have acetylcholine, and acetylcholine will be metabolized by acetylcholinesterase, this enzyme, and this will metabolize to the acetate and choline. Okay, this group of medication inhibit this enzyme. This group inhibit this enzyme. When you inhibit this enzyme with this group of medication, let me say neostigmine, pyridostigmine, physostigmine, when you inhibit this enzyme, the result will be enhanced and prolonged action of acetylcholine. So in this case, we try to mimic the action of acetylcholine by inhibit the enzyme that is responsible for metabolism of acetylcholine. So we are prevent metabolism of acetylcholine. Metabolism of acetylcholine lead to the increased level of acetylcholine in the human body or in the individuals. Speaking about the indirect acting irreversible cholinergic agonist, indirect acting irreversible. Speaking about indirect acting irreversible cholinergic agonist, we have icothiopate, phospholine, iodide. How this medication work? This medication inhibit acetylcholinesterase, inhibit the enzyme, but their effect longer laster and stay for a long time and could be permanent, and this could be lead to terminate of the enzyme. So we call this one irreversible. So this group of medication, icothiopate, considered like indirect irreversible cholinergic agonist by inhibit this enzyme irreversibly, and this will lead to the increased level of acetylcholine and cause overstimulation of the all receptor. It could be muscarinic receptor and nicotinic receptor. So when you inhibit this enzyme, irreversibly, this will lead to the overstimulation of muscarinic receptor and nicotinic receptor. And we know that these two types of receptor available in all human bodies, from the head to the heart to the GI system, urinary system, skeletal muscle, smooth muscle, secretion. Therefore, the patient will suffer from toxicity of increasing acetylcholine. Okay, moving to the maybe another group of, or group number 4 of acetylcholine agonist. Okay, group number 4 here, we can speak about this medication if the patient regarding group number 4, if the patient exposed to the pesticide or to the nerve gas, for example, from icothiopate or sarin gas, this is how this medication works. This medication irreversibly inhibit the enzyme, lead to the increased level of acetylcholine. So we have a high level of acetylcholine in our body. So the situation here, the patient will suffer from toxicity due to the overstimulation of receptors. So the result will be overstimulation of acetylcholine receptor, overstimulation. There could be muscarinic receptor or nicotinic receptor. How we can treat this situation? We have antidote So the antidote include the reactivation of this enzyme, reactivation of acetylcholinesterase. We have a medication called bralidoxim, protopam, bralidoxim. This medication reverse the effect of organophosphate and ecothiophate poisoning, which can cause excessive acetylcholine level. Okay, this slide here considered like one of the most important slide in autonomic nervous system. The colonoceptor characteristic. Here we talk about receptor. We talk about here in this slide. Maybe we focus on characteristic of acetylcholine receptor. So we have receptor. We look on the location of this receptor, how this receptor work, and what is the major function of this receptor. As you can see here, M1 receptor available in the neuron, sympathetic system, and postganglionic neuron. M1 receptor work on GQ protein. M3 receptor work on the GQ protein, if you like to remember that. However, M2 receptor work on the GI protein. Okay, so M1 receptor lead to the activate GQ protein. This will lead to increased IB3 and DAG, increased level of calcium. This will lead to the action potential depolarization. Could be contraction, could be increased secretion. Okay, M1 receptor through the GQ. M3 receptor, similar results, is available in the gland, smooth muscles, lead to the action potential and increased secretion with the M3. So M3 and M2 maybe present similar action, similar activity through the GQ. As you can see, both of them work on the GQ. Okay, regarding the M2 receptor. Okay, regarding M2 receptor, M2 receptor work on the GI protein, activate GI protein, and we know that GI protein lead to inhibitory effect, and this will lead to the decreased cyclic AMP, activate potassium channels. This will lead to the case of hyperpolarization. Okay, lead to the hyperpolarization. So if we talk about M2 in the heart, the result will be slow heart rate and slow decreased conductancy, smooth muscles and neurons. The result will be inhibitory effect. Okay, moving to the next group, we have nicotinic receptor. This nicotinic receptor could be available in the neuromuscular junction. In neuromuscular junction, here we are talking about skeletal muscles, and here we have another one, ganglia. When you have skeletal muscles, we have M, nicotinic receptor in the skeletal muscles, nicotinic muscles. So NM stands for nicotinic receptor in the skeletal muscles, motor in the blade. Then we have NN. Here we speak about ganglia or node. So the NN, a nicotinic receptor in the ganglia. And if you can see here, we have similar results. Both of them lead to the opening sodium channels, opening sodium and potassium channels, mainly the sodium channels. And this will lead to the depolarization, action potential, and contraction. Okay, this slide here present the distribution of cholinergic receptor. As you can see here, in the muscles, in the distribution of the cholinergic receptor. In the skeletal muscle, we have nicotinic receptor. In the adrenal gland, we have nicotinic receptor. Speaking about the cardiac muscle and the heart, we have M2 receptor, and we know that M2 receptor lead to the M2 receptor lead to the activation of GI protein, decrease cyclic AMP, decrease heart rate and contractility. And the pancreatic cells, we have M3 receptors. If you activate M3 receptor, the result will be increased secretion, exocrine gland secretion. Smooth muscles, we have M3, work on DQ, and this will lead to the increased secretion and increased contraction. Here we are talking mainly about the longitudinal muscle and the smooth muscle cells. So M3 GQ activate, increase calcium contraction, increase contraction, and what else we have? Increased secretion with the M3. So we are not talking about the adrenergic. Here we focus only on the muscarinic receptor. Okay, speaking about muscarinic receptor, they found that we have five subtype of muscarinic receptor: M1, 2, 3, 4, and 5. M1, 3, and 5. This will lead to the excitation and stimulatory effect through the GQ. M1, 3, and 5 work on GQ receptor, and this will lead to the excitation or excitatory effect. M2 and 4, this will lead to the inhibitory effect through the GI protein. Okay, the question now, which of the following muscarinic receptor could lead to the cellular excitation? The answer will be here: 1, M1, M3, and M5 muscarinic receptor. So these receptor, if you activate these receptor, the result will be excitatory effect. Okay, mainly we can find M1 and in the gastric parietal cells. We can find M2 mainly in the heart, some smooth muscles. M3 is widely distributed in the bladder, exocrine gland, smooth muscles. What is the result of activation of M2 receptor in the heart? So if you look on the heart there, if you look on what we have in the heart, M2 receptor, the result will be inhibitory effect. If you go to the previous slide, you can see here, if you clean this board a little bit, we have M2 receptor. If you activate it through the GQ protein, this will lead to the decreased contractility, inhibitory effect on the heart, decreased heart rate, decreased contractility. Okay, this slide here summarizes the action of acetylcholine. When acetylcholine bind to the muscarinic receptor, what happened? We know that I will go back a little bit. Acetylcholine affect both receptor, affect muscarinic receptor and nicotinic receptor. Here we are talking about muscarinic receptor. What happened here when acetylcholine activate muscarinic receptor? And we know that we have M1, M2, M3, M4, and M5, or the subtype of muscarinic receptor. What we found there? In the heart, we have the effect of acetylcholine on the heart will be bradycardia, slow heart rate, and we can type the receptor here, M2 receptor. And vascular effect, we have vasodilation. We need you to type here nitric oxide. So through the nitric oxide, acetylcholine increase nitric oxide. So I will say there, acetylcholine lead to the increase in nitric oxide. Nitric oxide cause vasodilation. Gastrointestinal tract, the result will be contraction, increased peristalsis, and decreased sphincter tone. So here we have contraction of longitudinal muscles. We need to type there here longitudinal muscle, and decrease sphincter muscle tone. We talk about circular muscle. So acetylcholine lead to the contraction of longitudinal muscles and relaxing or decreased tone of sphincter muscle or circular muscle. And the uterus, the acetylcholine increased tone of the uterus, and the bronchi, and the bronchi, the result will be contraction of the bronchi, and this will lead to the bronchoconstriction, another name bronchospasm, the same. So this will worsen the situation for patients suffer from asthma. Again, I will repeat it. If the patient suffer from asthma, the stimulate of muscarinic receptor will worsen the situation, and patient may suffer from severe asthma or acute asthma. So acetylcholine worsens the case of asthma. Effect of secretion, this is important things here. Acetylcholine in general work on M3 receptor, increase secretion. You can see here the arrow, increase saliva, secretion, increase bronchial secretion, increase sweat secretion, increase lacrimal secretion. So all the secretion will be increased by the acetylcholine effect. So two things we need to remember. Number one, two things we need to remember under the effect of acetylcholine. Smooth muscle cells, the effect of acetylcholine will be, the situation will be contraction. And number two, increase secretion in general. Okay, what about effect of acetylcholine on the eye? On the eye, we know that we have muscarinic receptor in the eye, M3 receptor mainly. The result will be meiosis. We discussed that in previous slide. Meiosis, because acetylcholine mainly innervate the circular muscle in the eye. Okay, so this is circular muscle around the eye. Okay, circular muscle innervated by acetylcholine. This is innervated by M3 receptor, and if you activate M3 receptor, the result will be meiosis. Okay, the result will be meiosis here. Okay, what else? We have spasm of ciliary body. So two things will be present the effect of acetylcholine on the eye. Number one, decreased diameter. So if you have this regular iris, under the effect of acetylcholine will become like small iris. And what else? We have spasm of ciliary body, unable to focus or accommodate when moving from a dark room to the light room. Okay, the purpose of this slide only to show us some medication work on the muscarinic receptor. We have pilocarpine. We have pilocarpine stimulate muscarinic receptor. Atropine inhibit muscarinic receptor. Then we have Botox inhibit release of acetylcholine. Spiderphenom increase release of acetylcholine. Then we have another group of medication inhibit the enzyme responsible for metabolism of acetylcholine called acetylcholinesterase inhibitor. Okay, so moving to the next type of receptor, we have nicotinic receptor. As you can see here, for the nicotinic receptor, we have two molecules of acetylcholine binding to the nicotinic receptor on the distinctive side of the nicotinic receptor. When acetylcholine bind to the receptor, the result will be opening sodium channels, allow sodium to enter the cell, and this will cause depolarization. So as you can see here, binding of two acetylcholine molecules elicits a conformational change that allowed sodium to enter the cells and cause depolarization. Nicotinic receptor, you can find nicotinic receptor in the central nervous system. We have nicotinic receptor in the adrenal medulla. We have nicotinic receptor in the ganglia. We have nicotinic receptor in a neuromuscular junction. So the location of nicotinic receptor: central nervous system, adrenal medulla, ganglia, neuromuscular junction. So the question now, which of the following is or are action of acetylcholine? Select all that apply. So we ask about the action of acetylcholine. What the action of acetylcholine on our body? Decrease heart rate, yes or no? Then we have bronchospasm, salivation, mydriasis, skeletal muscle contraction. Acetylcholine decrease heart rate through the M2 receptor. Bronchospasm through the M3 and M1 receptor. Salivation, increased secretion. Increased secretion. Okay, what about skeletal muscle contraction? Yes, through the nicotinic receptor, NM receptor. Mydriasis, this is wrong. Why? Because acetylcholine causes meiosis, not mydriasis. This is wrong. So this is correct. So we select A, B, C, and E for this question. So we have mnemonic for the capture that captures the muscarinic effect for acetylcholine. Acetylcholine action may cause defecation, diaphoresis, urination, meiosis, bronchospasm, bronchoria, emesis, lacrimation, salivation. This is not for dumbbell. So if you go with the dumbbell, D for defecation, U urination, M meiosis, bronchospasm, bronchoria. Then we have emesis, lacrimation, then salivation. We have another mnemonic. It's like could be another possible sludge B P B, sludge S for salivation, L lacrimation, urination, D defecation, GI upset, E for emesis, B first B bronchospasm, the second B bronchoria, and the third B will be bradycardia. So you can see here the mnemonic for the to remember the action of acetylcholine in the human body. Okay, as we discussed in the beginning, we have four main groups belong to the cholinergic agonist. The first group of medication belong to the cholinergic agonist. We call this group direct acting cholinergic agents or cholinomimetic agents that mimic the action of acetylcholine. As you can see here, we have three main medication. Could be more, but this is most popular medication in the clinical practice. We have bithanicol, we have pilocarpine. Okay, we have bithanicol, then we have pilocarpine, carbachol. So we have bithanicol, pilocarpine, and carbachol. Bithanicol mainly stimulate bithanicol. This medication mainly stimulate muscarinic receptor. This will lead to the contraction of detrusor muscles. Detrusor muscles represent the longitudinal muscle and the bladder, and this will lead to the contraction of the detrusor longitudinal muscle and relaxation of the trigon and the sphincter, and this will lead to the expulsion of urine, and this will enhance urination. Okay, clinical use of bithanicol. Bithanicol used for atonic bladder. Bithanicol used for intestine paralysis after for example, the surgery, and we have paralysis in the intestine. We use bithanicol to enhance contraction of the intestine. It's very important to remember there that we can use it in postpartum or postoperative non-obstructive urinary retention. So this is important here to address. We can use it for the patient suffer from urinary retention, and this medication help to patient to urinate, to expel urine outside the bladder. However, you have to be very careful about using this medication in patient with the benign prostatic hypertrophy. So if the patient suffer from benign prostatic hypertrophy, bithanicol consider contraindication. So because bithanicol contraindicated in patient with the benign prostatic hypertrophy. Okay, someone may ask why bithanicol. Someone may ask why bithanicol consider contraindication in a patient with a benign prostate hypertrophy. As we know that, I will minimize it a little bit. Speaking about the bladder, here, and this is a bladder, and this is another the bladder, and then we have the prostate. The prostate located here on the bladder neck. This is a prostate, cover the bladder neck. So this is a detrusor and skeletal muscle, longitudinal skeletal muscle. We have internal sphincter here and external sphincter here. This is a prostate here. Okay, when the patients are from benign prostatic hypertrophy, that means the prostate will be large. We have I will go with another color here, with this color here to show you the enlargement of prostate. So the prostate will block will obstruct the bladder neck. So in this case, the patient unable to urinate. So, if you prescribe Bethanicol enhance contraction of the bladder. However, the bladder neck is closed, and this case may lead to the rupture. So the bladder rupture. So for this reason here we consider Bethanicol contraindication in patient with the benign prostatic hypertrophy. Moving to the second medication, pilocarpine. Pilocarpine mainly available as eye drops. Pilocarpine mainly available as eye drops. Sometimes you can find it like spray, mouth spray for patients from dry mouth. So available in two forms: eye drops to treat glaucoma and spray to treat xerostomia. So we use pilocarpine for two medical cases: glaucoma as eye drops or xerostomia when the patient suffers from dry mouth. Okay, so what is pilocarpine? Pilocarpine considered like muscarinic. Pilocarpine considered like muscarinic agonist. So the Bethanicol muscarinic agonist, pilocarpine muscarinic agonist. Pilocarpine in the eye cause meiosis, reduce intraocular pressure, stimulate secretion of exocrine gland, so increase secretion of saliva. This is the reason we use pilocarpine for patients suffering from dry mouth. So the pilocarpine used for emergency treatment. So if the patient suffers from acute glaucoma, we use pilocarpine for the treatment. Sometimes we use it to induce meiosis during eye surgery, but we need to remember this is the main indication for pilocarpine for emergency acute glaucoma. Sometimes we use pilocarpine to treat patients from dry mouth or xerostomia. So as you can see here, we have pilocarpine as eye drops, could be gel or oral tablet, and available as spray for dry mouth. Okay, the last medication on the list here, carbachol. Carbachol is a medication able to stimulate muscarinic receptor and nicotinic receptor. Now we have something new for us, because if you go back to the Bethanicol only stimulate muscarinic receptor. What about pilocarpine? Pilocarpine only stimulate muscarinic receptor. However, if you look on the carbachol stimulate muscarinic receptor and nicotinic receptor. This is a characteristic of carbachol. Carbachol may cause meiosis for pupil construction, reduce intraocular pressure. We use it locally on the eye. It's very rare to use in the practice due to the effect on the nicotinic receptor and muscarinic receptor. Carbachol affects the entire body, so we don't recommend to use it. Available only as ophthalmic. It's like for local effect. We don't prefer to use this medication because this medication maybe carry the systemic effect on the entire body, the entire system, the brain, the eye, the heart, the lung, the intestine, the muscles. We don't recommend to use it, similar to the acetylcholine. Okay, what's the purpose of this? So the purpose of this table here to show you the muscarinic action or muscarinic receptor here, nicotinic receptor. So which one will affect nicotinic muscarinic? And we have enzyme cholinesterase enzyme. We know that acetylcholine will be metabolized by acetylcholinesterase. That's what's well known that. Acetylcholine stimulate muscarinic receptor. Yes. Acetylcholine stimulate nicotinic receptor. Yes, that's correct. All these correct. What about, for example, Bethanicol? Bethanicol mainly stimulate muscarinic receptor, no effect on nicotinic receptor, and the acetylcholinesterase does not metabolize the Bethanicol. So we need to remember that Bethanicol stimulate muscarinic receptor mainly, no effect on the nicotinic receptor, and the enzyme unable to metabolize the Bethanicol. The same apply for pilocarpine. The same apply for pilocarpine here. Okay, and no here. So the same will be applied. Carbachol, no effect of enzyme on carbachol, but carbachol stimulate both receptor, nicotinic receptor and muscarinic receptor. Okay, speaking about adverse effect of cholinergic agonist, when you prescribe acetylcholine, carbachol, bethanicol, what happened? The patient, this is a unwanted adverse effect from the cholinergic agonist. The patient may suffer from nausea, vomiting, diarrhea, abdominal pain, abdominal cramps, as excessive salivation, profound sweating, hyperhidrosis, for regarding the heart, decreased heart rate. This will lead to the dizziness and fainting, decreased heart rate. We call this one bradycardia. Bradycardia, decreased heart rate, hypotension, due to the vasodilation, bronchoconstriction. Here the patient may worsen the situation of asthma and COPD, increase urinary frequency, and the patient will go to the bathroom very often. The cholinergic agonist, acetylcholine, may cause meiosis, lacrimation, increase excessive tearing of the eyes due to the effect of nicotinic receptor. The result will be contraction of skeletal muscle. Central nervous system, the mismedication may cause headache, dizziness, confusion, and so on. Okay. Speaking about the pharmacological effect of the cholinergic agonist or muscarinic effect on the eye, as you can see in this slide here, we have muscarinic M3 receptor in the eye, muscarinic M3 receptor in the eye, available in the iris sphincter muscles and ciliary muscles. And this will lead to, with the cholinergic agonist, this will lead to the activation of iris sphincter muscle, lead to meiosis, pupil constriction, and lead to the accommodation spasm. We talk about spasm of accommodation here, and this will lead to the focusing of the lens. Two medication here we speak about. We already discussed the pilocarpine, and this is the normal eye, and this is the opposite, the atropine. So as you can see, this is represent the iris. You can see the diameter of the iris here. The diameter of the iris, normal diameters here. When you apply pilocarpine as eye drops, this will lead to the meiosis. And here we talk about the decrease. Here we talk about the decreased diameter of the pupil. Decreased diameter of the pupil. You can see it here. It's very clear. Decreased diameter of the pupil after applying of pilocarpine. However, when you apply by atropine, black muscarinic receptor in the eye, pilocarpine, this will lead to the mydriasis. So you can see the mydriasis under the effect of atropine. So atropine causes mydriasis, and normally you use it during surgery, for example, to do some eye surgery, or for during eye examination, we use atropine. Or when you do the retina examination, we use atropine. We use pilocarpine to treat glaucoma, and we know that pilocarpine induces meiosis. However, atropine causes mydriasis. As we mentioned in the beginning of this lecture, we have four main groups related to the cholinergic agonist. We have direct acting cholinergic agonist, then we have indirect acting reversible agonist, then we have indirect acting irreversible, then we have reactivators at acetylcholinesterase. We have covered the first group of medication belong to the cholinergic agonist. The second part will focus on the indirect acting reversible cholinergic agonist. So we are going to the second part of the cholinergic agonist now. As you can see here in this slide, we are currently speaking about indirect acting cholinomimetic agent, which may be the same meaning of anticholinesterase. This is a reversible enzyme inhibitor, anticholinesterase inhibitor. So we inhibit the enzyme that's responsible for acetylcholine. This will lead to the increased level of acetylcholine in our body. I need to mention something here important for us. Normally we don't use acetylcholine in the practice, because acetylcholine considered like non-specific action. It has multiplicity of action. Acetylcholine, if you prescribe acetylcholine to your patient, acetylcholine will stimulate the brain, they will stimulate the eye, will stimulate the neurons, will stimulate the heart, the muscles, the lung. So it's like this is a multiplicity of action, a lot of action. We need the medication to be selective, for example. But if you need to increase level of acetylcholine in the human body, the best way to give to inhibit the enzyme responsible for metabolism of acetylcholine, this will lead to the increased level of acetylcholine. So for this reason, we prescribe acetylcholinesterase inhibitor, AChEI. Okay, as you can see here in this graph, the acetylcholinesterase enzyme, this enzyme responsible for metabolism of acetylcholine, and this enzyme metabolizes acetylcholine to the acetate and choline, and choline will be reused again, as you can see here, reused again as a recycle or reuptake in the neuron. Responsible, this enzyme acetylcholinesterase, responsible for terminating the action of acetylcholine. Okay, now we have a group of medication. Now we talk about the group of medication. Okay, speaking about the acetylcholinesterase inhibitors, indirect acting, reversible. We need to remember that we have indirect acting cholinomimetic agent, considered like anticholinesterase, reversible, AChEIs, increase activity of acetylcholine, increase activity of cholinergic indirectly, yes, through the inhibit the enzyme. This will prolong action of lifespan of the acetylcholine. List of medication on this list here, we have idrophonium, neostigmine, physostigmine, pyridostigmine, tacrine, danabazil, rivastigmine, galantamine. So we have list of medication belong to the acetylcholinesterase, and this medication considered like reversible. So reversible mean I'll bind to the receptor and leave the receptor later on. Idrophonium, neostigmine, physostigmine, pyridostigmine, tacrine, danabazil, rivastigmine. As you can see here, when you inhibit this enzyme here, the result will be increased level of acetylcholine, increased activity of acetylcholine. And increased activity of acetylcholine mean activation of nicotinic receptor and muscarinic receptor. List of medication here, we have the reversible anticholinesterase, idrophonium, neostigmine, physostigmine, pyridostigmine, and then we have a group of medication used for Alzheimer disease. We have tacrine, danabazil, rivastigmine, galantamine. I will repeat it. For Alzheimer disease, anticholinesterase inhibitor or reversible, we have tacrine, danabazil, rivastigmine, galantamine. Another group of medication considered like irreversible, we have icothiopate, parathion, malathion. So for indirect acting cholinergic agonist irreversible, we have organophosphate compound, we have icothiopate, parathion, and malathion, and this medication used for as insecticide. This medication, the first group of medication, indirect acting cholinesterase reversible, idrophonium, neostigmine, physostigmine, pyridostigmine, mainly used for Myasthenia Gravis. The second group, this is the first group for Myasthenia Gravis. The second group used for Alzheimer disease, tacrine, danabazil, rivastigmine, galantamine. And the third group, irreversible, used for the purpose of the insecticide, not for the human use. This is a comparative table to compare between several types of anticholinesterase, reversible anticholinesterase, regarding duration of action, properties, and uses. Very important table, is very demand table. We need to differentiate between these agents and compare with the clinical application of these agents. The first one, idrophonium. or idrafonium. Idrafonium, duration of action to 10 to 20 minutes. As you can see here, duration of action 10 to 20 minutes. Short acting acetylcholinesterase inhibitor. Okay, due to the availability of other agent, idrafonium use to become limited. So idrafonium use has become limited. Normally use it for diagnosis of myasthenia gravis. So idrafonium because the short duration of action. Now moving to the neostigmine. The duration of action 30 minutes to 2 hours. The neostigmine does not cross blood-brain barrier, does not enter the central nervous system. Okay, moving to the uses. Neostigmine used for patients from myasthenia gravis. Neostigmine used for reversal of non-depolarizing relaxing agents. Okay, moving to the Physostigmine. Physostigmine similar to the neostigmine, 30 minutes to 2 hours. The difference between neostigmine and Physostigmine. Physostigmine able to enter the central nervous system, able to cross blood-brain barrier. Then we can use the Physostigmine to reverse of non-depolarizing muscle relaxants. Okay, moving to the last one, Pyridostigmine. As you can see, the duration is for Pyridostigmine, we have long duration of action between like 3 to 6 hours. Okay, for Pyridostigmine, we have the question mark there. Okay, so we use Pyridostigmine for chronic management of myasthenia gravis. So idrafonium, we use it for diagnosis of myasthenia gravis. On the other hand, Pyridostigmine used for chronic management of myasthenia gravis. We need to maybe focus on important issue here, talking about the acetylcholinesterase inhibitor. This group of medication bind reversibly to the acetylcholine, mean that bind and leave the receptor if you have any increased level of, according to the low mass of action. Idrafonium available as IV injection, used for diagnosis of myasthenia gravis. However, for the treatment, we have Pyridostigmine. Okay, when the patient come to the clinic suffer from myasthenia gravis, and we prescribe idrafonium IV, and you know that the duration of action 10 to 20 minutes. So if the patient suffer from myasthenia gravis, the symptoms will be improved after 10 to 20 minutes. However, if the muscle weaknesses is not related to myasthenia gravis, related to something else, so that we are not going to see the improvement. So idrafonium could be used for differential diagnosis to see if this muscle weaknesses, muscle fatigue, is this muscle weakness and fatigue related to myasthenia gravis or something else? So idrafonium used for differential diagnosis, for diagnosis of myasthenia gravis. Okay, let me explain how neostigmine reverse the action of, if you go to the slide here, you can see here neostigmine used to the treatment of myasthenia gravis, number 1. Number 2, neostigmine could be used for reversal of non-depolarizing agents. Here we have the whiteboard. Try to explain what happened there. If I maximize this image here, when you have patient under general anesthesia, or going to the general anesthesia, we use a neuromuscular blocker like atracorium, cis-atracorium, pancuronium to induce skeletal muscle relaxation and paralysis. When the patient finishes the surgery and he's in the recovery room, the patient will the physician and the specialist will try to remove the blocker from the neuromuscular junction. As we mentioned, we don't use acetylcholine to reverse the action of neuromuscular blockers. However, we use neostigmine. Neostigmine will lead to the increased level of acetylcholine. This we already explained how, because neostigmine inhibit the enzyme responsible for metabolism of acetylcholine. So increasing level of acetylcholine, acetylcholine in this case will compete with the neuromuscular junction blocker, and the patient will regain muscle tone. In this table is very important. The first question from this table here, Which of the following anticholinergic agonist, anticholinergic agent used for diagnosis of myasthenia gravis? We have idrafonium. Which of the following medication used for treatment of myasthenia gravis? We have pyridostigmine or neostigmine. Which of the following medication could be used for the reversal of non-depolarizing muscle relaxants? We have neostigmine and physostigmine. Which of these medication able to cross blood-brain barrier? Physostigmine. And here we compare between physostigmine, neostigmine. As you can see here from this graph, I will try to make it highlight. So neostigmine prevent post-operative abdominal pain, distension, and urinary retention, because neostigmine increase level of acetylcholine and enhance urination and enhance abdominal movement. Neostigmine used for treatment of myasthenia gravis. Neostigmine could be used as antidote and recovery from neuromuscular blocking agents, and we explained the concept already. Neostigmine duration of action between 30 minutes to 2 hours. Physostigmine is the same, enhance intestinal and bladder motility, similar effect. Now, physostigmine reverse central nervous system cardiac effect of tricyclic antidepressant. Physostigmine reverse central nervous system effect of atropine. So when you have effect on the brain regarding atropine, we use physostigmine to overcome. Physostigmine uncharged and able to cross blood-brain barrier. Quick review about the medical case myasthenia gravis. As you can see here, myasthenia gravis is considered like autoimmune disease, a progressive disease associated with the decreased number of cholinergic receptor at the neuromuscular junction. This will lead to the decreased release of acetylcholine, and the patient suffers from skeletal muscle weaknesses and fatigue. In advanced age, this skeletal muscle weaknesses and fatigue will arrive to the respiratory system, and the patient will need to place on the respiratory support or ventilator. The issue here with the myasthenia gravis, we don't have a cure available. Cholinesterase inhibitors such as neostigmine, pyridostigmine may alleviate the symptoms, may alleviate the muscular fatigue. Okay, so what we have so far here, another group of anticholinesterase inhibitor, inhibitor agent, a group of medication, tacrine, danabazil, rivastigmine, galantamine, and this medication used for Alzheimer disease. As you can see here, acetylcholine is very important for the function of central nervous system. In patients with Alzheimer disease, they found that we have marked significant loss of the cholinergic neurons. Therefore, the treatment will be directed towards the enhanced activity of acetylcholine in the brain. And as we mentioned, we don't use acetylcholine in the practice. We use something to enhance, to increase level of acetylcholine in the brain. Tacrine, the first available medication, belong to the Alzheimer disease treatment, but tacrine withdraw from the practice due to the hepatotoxicity. Then we move to the danabazil and rivastigmine. Danabazil, rivastigmine, another group of medication. Danabazil, rivastigmine, this three medication, galantamine, danabazil, rivastigmine, galantamine, this three group of medication may delay the progression of the disease, but the disease cannot stop. Okay, galantamine, rivastigmine, and danabazil considered like first-line agent for Alzheimer disease, first-line treatment, Alzheimer disease. This medication can be used, this group of medication can be used for the patient with the patient with Alzheimer disease with the memantine, and memantine considered like antagonist for the N-methyl aspartate. So we can use it as combination treatment between two medication, memantine and danabazil, rivastigmine, galantamine. So the question from this slide here, which of the following medication belong to the anticholinergic, anticholinesterase inhibitor and used for Alzheimer's disease. We have danabazil, rivastigmine, galantamine. Memantine used for treatment of Alzheimer's disease. Memantine, we have it here. Memantine used for Alzheimer's disease. Ben, so memantine used for Alzheimer's disease. What is the mechanism of action of memantine? Memantine considered like N-methyl deaspartate antagonist. Okay, this will conclude the second part of the cholinergic agonist. The first part was direct acting cholinergic agonist. The second part was indirect acting reversible. We spoke about neostigmine, edorphonium, physostigmine, pyridostigmine, tacrine, galantamine, danabazil, list of medication for the available in the practice for Alzheimer's disease, Myasthenia Gravis, reversible of neuromuscular junction. So the next part will be to speak about Anticholinesterases or Anticholinesterases irreversible agents. Here we are going to speak about this part. This is important part. It's not available for clinical practice. Normally you use it for as insecticide or like as local drops on the eye for glaucoma. Okay, next, as I mentioned there, indirect acting cholinomimetic agent. Here we are speaking about anticholinesterase, irreversible. Okay, so what we have here, we have a group of medication called organophosphate. As you can see here, we have a group of medication called organophosphate. One of these medication, icothiopate. This medication binds covalently to the acetylcholinesterase. Covalently mean irreversible here, non-competitive. Stay on the receptor. Okay, and this will lead to the inactivation of the enzyme and prolonged action of acetylcholine. So the end result will be prolonged action of acetylcholine. So we know that acetylcholine will affect the entire human body, will cause overstimulation. So as you can see here, we have overstimulation of acetylcholine. Overstimulation, this will lead to stimulate nicotinic receptor, muscarinic receptor. This will affect every part of the body. Many of these agents, many of these drugs belong to the irreversible, considered like many of these drugs considered like extremely toxic. Icothiopate, parathion, malathion, extremely toxic and could be used as a nerve gas in the military service. Related to these compound, as we can see here, we have icothiopate, one of these. Then we move to the parathion. Then we have malathion, and this medication used as insecticide. So what happened when the patient exposed? What happened when the patient exposed to this agent? Okay, when the patient exposed to this agent, here we have a major sign and symptoms. As you can see here, the major sign and symptoms include overstimulation of nicotinic receptor and overstimulation of muscarinic receptor. So we have it here from the CDC emergency treatment. Okay, if you click on the CDC treatment, emergency treatment. Okay, I will share the screen with you from the CDC. Nerve agent and organophosphate, pesticide, poisoning, and another name will be sarin gas, and we have several names there. And sign symptoms you can see here, because all receptor will be stimulated. The patient may suffer from central nervous system sign symptoms, meiosis, headache, restlessness, confusion, loss of consciousness, coma, and this will be very risky for the patient here. Patient may suffer from increased secretion, rhinorrhea, bronchorrhea, dizziness, wheezing, dyspnea, chest tightness. Okay, cardiovascular here, tachycardia, hypertension, bradycardia. Okay, so gastrointestinal, we have a lot of signs. You can see it here. Okay, so we have overstimulation of nicotinic and muscarinic receptor. All these considered like overstimulation from coming from muscarinic receptor, as you can see it, and it's already covered in the previous slide. Toxicity most frequently seen with the pesticide use, and initially you can see the patients are from sludge PPP, and that Mnemonic. I refer you to the slide regarding this Mnemonic. The patients are from central nervous system stimulation, depolarization of skeletal neuromuscular junction. The patients are from skeletal muscle contraction, severe skeletal muscle contraction appear as fasciculations. How to treat this patient? This is an important issue here. We try to maintain vital sign, look on the blood pressure, respiratory rate, pupil of the eye, temperature. So we pulse, for example, we look on the maintain vital sign. Decontaminated, prescribe or inject atropine. The antidote will be bralidoxim 2-PAM anticholinergic reactivator. How to treat patient with organophosphate toxicity? We need bralidoxim as antidote to reactivate the acetylcholinesterase. We need to use diazepam to relieve convulsions and epilepsy, for example, if you have it there. We use atropine to prevent muscarinic effect in this patient, especially speaking about the bronchial and salivary saliva secretion. Okay, so I will go back to the previous slide again. Okay, so the most popular, the most important medication used for patients suffer from organophosphate toxicity will be bralidoxim. Bralidoxim considered like antidote. If the patient suffer from convulsions, we go with the prescribed diazepam. If the patient suffer from stimulation of muscarinic receptor, we prescribe atropine. So we have several approaches for the patient. The antidote will be bralidoxim 2-PAM to reactivate the enzyme. Diazepam to control convulsions. If we have convulsions, we use atropine to prevent muscarinic activation. Okay, this will conclude our lecture about cholinergic agonists. The next lecture we focus on cholinergic antagonists, especially talk about atropine, atracorium, ipratropium, oxybutynin, and benzotropium. We have all these medication with the different clinical applications, such as Parkinson's disease, such as skeletal muscle and asthma, overactive bladder. All these clinical cases will be covered in the next lecture.